Good afternoon to all. Welcome to the SLVA webinar series. Today the lecture is on echocardiography conducted by our colleague Dr. Mathota. And as usual, the structure of the program would be there will be a first 1+ hour lecture, then followed by a Q&A session. During the Q&A session, you can ask either live questions from Dr. Mathota, or else you can type your questions in this chat box option so that Dr. Mathota would be able to answer you. So that's the structure of this program. And also this program goes live in our YouTube channel. So if anybody interested, you can join through our YouTube channel. And also request to mute your microphones. Please mute your microphones so that we can have an uninterrupted session. And before we start, I would like to invite Dr. Erandika Gunawardana, President SLVA, to address this virtual gathering and to welcome you. Dr. Erandika.
Thank you very much, Dr. Chandika, for your introduction, actually. So welcome you all today for this webinar on basic endocardiography conducted by our colleague, Dr. Mathota. Actually, this is the 7th webinar, I suppose, we are conducting by the SLVA, because we compelled to shift to this webinar, platform, as per the new normal situation in the country due to this pandemic. And I know this, we have here gathering of, there have been a lot of registrations here, had been placed, nearly 200 participants were there in the registration. So this is one of the biggest webinars that we are going to conduct today. And welcome you all for this webinar, my teachers and my dear colleagues and senior veterinarians and the colleagues who are joining from overseas especially. And this will be a very wonderful one on this Sunday. So take home messages will be there for you all. And welcoming you all for this webinar today by the SLVA. I invite Dr. Chandika to conduct the program. Thank you very much, Chandika.
Thank you, Dr. Erandika. So before the lecture, now I would invite Dr. Sugat Premachandra, Secretary SLVA, to introduce our speaker today, Dr. Mathota.
Thank you very much, Dr. Chandika. It's a pleasure to introduce our resource person today, Dr. Tushara Mathota. Dr. Tushara Mathota graduated from the Faculty of Veterinary Medicine and Animal Science, University of Pericardium in 2006. He obtained postgraduate diploma in toxicology from Faculty of Medicine, University of Colombo in 2009. He worked at BVSc Animal Hospital as a veterinary surgeon from 2007 to 2016. While his work as veterinary surgeon, he was interested in latest technology in veterinary medicine. He was able to introduce first veterinary computerized radiographic system in Sri Lanka, CR system in Sri Lanka. He has developed complete veterinary clinic management software, and currently that software is being used by several veterinary hospitals in Sri Lanka. He followed online veterinary radiology course in 2013. Then he followed online abdominal ultrasound and echocardiography from Royal Veterinary College in 2015. He is working as a visiting lecturer in Faculty of Livestock, Fisheries and Nutrition, YMB University of Sri Lanka. Currently, he is working as a chief veterinary surgeon at Super Pet Care, Malambe, and a visiting veterinary surgeon for ultrasound scanning and echocardiography in many private hospitals in Sri Lanka. On behalf of Sri Lanka Veterinary Association, I would like to invite Dr. Tushara Mathota to conduct the program. Thank you.
Thank you very much, Dr. Sugat, for the introduction of Dr. Mathota. Before we actually go into the lecture, I would again remind you all the participants to please mute your microphone so that we can have an uninterrupted lecture session. Thank you, and Dr. Mathota, you can start the lecture.
Thank you, Dr. Sugat, for introducing me. First of all I want to thank SLVA and all colleagues for inviting me as a resource person in this webinar series. Today, we are going to talk about basic echocardiography of dogs and cats. Here, we'll talk some technical aspect of this echocardiography. First, we will start what is this echocardiography and why do we need to do this echocardiography? Okay, why do we need to do this echocardiography? First question is that. So we have to do echocardiography if animal is having some clinical signs. If we have some clinical signs of maybe dilated cardiomyopathy or hypertrophic cardiomyopathy, or if you find any murmurs, then we'll have to refer for echocardiographic examination. This echocardiography is an advanced diagnostic tool. If we want to do this echocardiography, we have to do some extensive training. Otherwise, we can't do this echocardiography because it's training is very important thing to do this echocardiography. If you find any clinical signs, I have listed this clinical signs. When we do clinical examination, if the patient is having exercise intolerance, syncope, cyanosis, any arrhythmias, or sometimes we can clinically find pleural effusion, ascites, or pericardial effusion. Then to confirm that, we have to go to echocardiography. Then we can diagnose some type of cardiac neoplasias. Sometimes patients are having fever with unknown origin. Sometimes it can be due to endocarditis or alveolar endocarditis. So we can confirm it by using this echocardiography. Sometimes puppies and kittens, stunt growth in puppies and kittens can be cardiac cause. So we can diagnose those things using echocardiography. Then these are the common things we can find in echocardiography. Usually here we diagnose dilated cardiomyopathy. This is very easy to diagnose with echocardiography. Then hypertrophic cardiomyopathy. This is a disease of cat. Usually cat get this disease, hypertrophic cardiomyopathy. DCM is usually get large breed dogs. In large breed dogs, you get dilated cardiomyopathy. So we can diagnose and confirm this disease with echocardiography. Then we can see chamber enlargement. Sometimes with high blood pressure or some other reasons, animal get cardiac chamber enlargement. So we can diagnose those chamber enlargement with echocardiography. Other thing is degenerative mitral valve disease. Some small breed dogs get this degenerative mitral valve disease. So we can confirm and diagnose this mitral valve disease. Other thing, sometimes there are some valve defect, tricuspid valve defect, maybe aortic valve defect. So we can confirm those valve defects using echocardiography. Then effusions, pericardial effusion, there may be pleural effusion. So we can diagnose those effusions, and sometimes we can drain those effusions. Ultrasound guided draining we can do with this training. Then sometimes cardiac neoplasia. We can find some cardiac neoplasia, and sometimes we can get samples. Some places we can't get samples. So we can diagnose those neoplasia using echocardiography. Then next thing is valvular endocarditis. We can see vegetative bacterial growth in heart valves, especially in tricuspid valve and mitral valves. So to do echocardiography, we need a special machine. So this machine should have some technical requirement. Usually this is the ultrasound machine we use in Sri Lanka. We can use this ESOT machine or some Chinese machine here. So this machine should have B-mode imaging facility. All the ultrasound machine we have this B-mode imaging facility. It's a 2D image. We can get black and white image of patient. Then M-mode examination. M-mode means I'll explain that later. Then should have color Doppler examination. And Doppler examination we should have color Doppler, pulse wave Doppler, and continuous wave Doppler. to do complete echocardiography, we should have these facilities in ultrasound machine. Then the ultrasound probe. In ultrasound examination, we need a special probe. In normal ultrasound machine, we have this two type of probe. This first one, this one is called a microconvex probe. This one is phase array probe. So I think you all can see this pointer. This phase array probe is used to do echocardiography because we are looking at the heart through intercostal spaces. It's very small spaces is there. So to see through that space, we need small footprint. This phase array probe has very small footprint and we can see large area inside. If you use this microconvex probe, the footprint is little bit larger. So sometimes it's a little bit difficult to see the full heart image. So best probe is phase array probe for echocardiography. But nowadays in Sri Lanka, we are using this both probe for doing echocardiography. The frequency range, the optimum frequency range 2 to 8 megahertz to see the heart. If we do echocardiography in large breed dogs, we have to use low frequency because the ultrasound penetration is very low. If we go to high frequency, but in small breed dogs, we can do high frequency ultrasound examination up to 8, maybe sometimes up to 10 megahertz. Then we need special table. To do echocardiography, we need this type of table. In this table, we have special space. Some part we have to cut off and remove from here. Then we can keep the animal on this table in lateral recumbency, and we can keep the probe from bottom of this table and see. Here we have 2 notches in this table. That's because we can see animal in left lateral recumbency and right lateral recumbency. Because in this table, we can see only on right lateral recumbency. Sometimes we can see left lateral recumbency without this notch on the table. Then we move to the animal positioning. Usually we keep animal in right lateral recumbency. When we keep right lateral recumbency, we have to shave the fur on this area, just below the elbow joint. This is on usually 2 to 6th intercostal space. 2 to 6th intercostal space, we have to shave this area, then we can see the image clearly. If you get without shaving, you have to apply a lot of surgical spirit and a lot of gel, and you can see the image, but image is not that clear. So when we examine the animal on left lateral recumbency, we have to shave this area. This is apical area of the heart. We can see, we can touch this area and see the feel the apex beat and find this area and shave this area. This is more caudal to the heart because in this left lateral recumbency, we see apical views. I will explain those views later. Then, when we keep animal right lateral recumbency, we can see heart in the chest cavity in between, usually in between 2 to 6th rib. That is the space heart lies on the chest cavity. So we have to keep the probe from bottom. So when we keep the probe, probe from bottom, usually this heart lies on right chest wall. So we can easily see the ultrasound image. If we keep the probe on this left chest wall, the lung is there. So ultrasound cannot penetrate through air. Ultrasound cannot penetrate through air, and it won't generate any image if you keep the probe on upper side. So we always have to go from bottom side. Sometimes in ultrasound examination, echocardiography, we do examination animal on standing position. So when we do this animal on its standing position, it's a little bit difficult to focus the image, but sometimes we have to do that. We will talk that later. Then echocardiography. When we do echocardiography, there's a standardized protocol for certain views. We use certain standard views. When we talk about abdominal scanning, we don't have that type of standard images. But in echocardiography, whoever do this echocardiography, we have to get standard image. Then only we can do the measurement and do the interpretation. If you can't get the standard image, then sometimes the interpretation may be incorrect. So always when we do echocardiography, we have to try to get the standard image. To get this standard image, we have to use different cardiographic modalities. Earlier also I talked about these modalities. First thing, 2D image. In 2D image, we get cross sections. Normally, maybe longitudinal section or cross section. This is grayscale image. Here you can see this is a cross section of heart. In this cross section, when we get the image of this cross section from ultrasound scanning, or maybe in echocardiography, we can see this structure like this. Usually we can get very clear image. Getting this image, actually this is real-time image, it's moving, we can see this movement. Then we can assess the cardiac size and some anatomical changes. If there are some anatomical changes, we can assess using this view. Then we have M-mode image. In M-mode image, we have a good time resolution on this image. This is 2D image, this B-mode image. In this B-mode image, we apply a cursor line here. This cursor, along this cursor line, we get movement over the time. This is called M-mode view. In M-mode, we get movement over the time. This is mitral valve view, so we can see the mitral valve movement over time. So this view, we can assess myocardial and valvular movements. In this view, we do some measurements and we do some calculations of the heart. So I'll explain those measurements later. This is called M-mode. Then we come to color Doppler. Color Doppler is usually this is we can measure the velocities, movements, the fluid movements in the heart. The blood flow is there. So if the blood is flowing away from us or away from the probe, it gives blue color here. If the blood moves towards the probe, it gives red color. This is the definition of this color. In color Doppler, we can identify the movement direction using this. If moving away from us, it's blue color. If moving towards us, it's red color. Then we get bright blue or yellow color in turbulence. In turbulence, we get turbulence when there's a block or when there's some obstruction or regurgitation or something. Here, this image of mitral regurgitation, we get turbulence jet. This we can see this turbulence here. Then we can easily identify the blood flow direction. If there's a blood flow to wrong direction, we can easily identify using color Doppler. But the measurement we do in this color Doppler, it's subjective. It's not a very accurate measurement, but we can assess. Then we go to this another name for this color Doppler. Some machines we say CFM, color flow map. That is another name for this color Doppler. Then Doppler, there are another two types of Doppler. Actually, there are three types, but nowadays today I'm going to talk about only two types. We can measure the velocities using these two types. First thing is pulse wave Doppler. This pulse wave Doppler, we can measure the velocity of blood flow in certain point. This is we have applied this cursor over mitral valve. Then we can measure the fluid blood movement over mitral valve, and we can get the map. This is the fluid movement over time. But there's a disadvantage of this pulse wave Doppler. The pulse wave Doppler, we can't measure higher velocities. We can measure velocity up to limited amount. Then continuous wave Doppler, we can measure higher velocities, but in continuous wave Doppler, there's a disadvantage. We can't apply specific point. It measures the velocity along this line. So it gets the velocity, but it's along this line. We can't apply any specific point on continuous wave Doppler, but it can measure very high velocities. In mitral regurgitation or aortic valve regurgitation, you get very high velocities. So we can measure those velocities using continuous wave Doppler. So to do this echocardiography, in the machine, we should have these facilities. Then it's easy to perform a basic echocardiography. Then, when we come to echocardiography, I told you there are standard views. These are the standard views. First thing, we look from right side of the heart. First view, right parasternal, long axis, 4-chamber view. Here we see about 4 chambers of the heart. Then second view, right parasternal, long axis, 5-chamber view. We can see 5 chambers of the heart. Then we move to right parasternal, short axis views. There are 3 short axis views. First thing, heart base view. This heart base, we can see aortic valve. This view sometimes called benchmark view. These views, when we look at this view, we can see benchmark. That's why usually they call this benchmark view. Then mitral valve view. In mitral valve view, we can see the movement of the mitral valve. This is called fish mouth view. Then left ventricular view. Left ventricular view, we can see 2 papillary muscles on either side of the left ventricle. So this is called mushroom view. So we will see what next view is. Then we move to left side. In left side, we can see left apical 4-chamber view, left apical 5-chamber view. Then there are another views. It's called subpostal view. We can see through the diaphragm. We can see the heart using this view. Actually, from abdomen, we see the heart in this subpostal view. Other view is left parasternal views. Today, I'm not going to talk about those views. This is the first views. First, we have to get the optimized view. This is when you get the image, it should be very clear image and standard image. So it is called optimized view. So let's see how do we obtain these optimized views. First view we are going to talk about is right parasternal, long axis 4-chamber view. The right parasternal means we are looking from right side. Here we keep the probe on the right chest wall in between 3rd to 4th intercostal space. This is right parasternal. We are seeing through the intercostal space. Then we see the long axis of the heart. It is called long axis. We can see long axis of the heart. This is how we obtain this view. First thing, we keep the animal on right lateral recumbency. Then, keeping the right lateral recumbency, we have shaved that area of the animal, the chest wall. Then keep the probe in between 3rd or 4th intercostal space. When you keep the probe, there's a marker on the probe. One side, there's a marker. This marker direct towards the vertebral column of the animal. This is called 12 o'clock position. This probe marker direct towards this vertebral column. Then we have to get angle this probe 45 degrees to the chest wall. This is the chest wall. We have to get angle. I will show you. This is the chest wall. This is the probe. This angle should be 45 degrees. So I'll draw it here. Then I'll explain here also. This is animal on right lateral recumbency. Then we can see the heart here inside the chest. So we use 1, 2, 3, third intercostal space, and we keep the probe here. So when we keep the probe, you can see this ultrasound beam goes like this. So we can see the heart in the scan image. When we keep the probe, we direct the pointer towards this 12 o'clock position or the vertebral column of the animal. Then this is how we see the heart. This is the heart cross section. So ultrasound beam goes like this to the heart. So this is the probe. So let's see, this is the image. When this our screen, we have to get this image to our screen. When we get this image to our screen, it's get upside down like this. So we will get the image upside down. Then you can see this is the image you see. You can see this is the cross section of the heart. The same thing we can see this image. You will see heart cardiac chambers. I will explain those things later. We can see this image, but when we keep the probe, heart is like this in the animal body, but we get upside down image in the screen. This is the standard image. This is called right parasternal long axis 4-chamber view. In this view, we can see 4 chambers. That's why we told it. We call this 4-chamber view. First thing, left ventricle. We can see this large left ventricle here. Then left atrium, right ventricle, right atrium. Here we can see intraventricular septum. Here you can see the posterior wall of left ventricle. Here you can see the anterior wall of right ventricle. Then you can see 2 valves. This is the tricuspid valve here. Here you can see mitral valve. This is the 4-chamber view. In this 4-chamber view, those things we can evaluate these structures. If you focus this view very clearly, it's very easy to interpret these things. Then what we can diagnose using this view. In this view, we measure the ventricular wall thickness. When we measure ventricular wall thickness, the posterior wall of left ventricle is usually double the size of right ventricular anterior wall. Here, right ventricular anterior wall, this wall thickness is usually right ventricular wall is half of the left ventricular posterior wall size. Then we can see same size intraventricular septum and posterior wall. We can see this mitral valve and tricuspid valve. This tricuspid valve more apical than mitral valve. You can see this, there's a little space here. This is not in same level. Then sometimes if there's thick mitral valve, we can see if there's a thickness of mitral valve, or we can see if there's any endocarditis or any bacterial growth in this mitral valve or tricuspid valve on this view. Then sometimes mitral valve prolapse. You can see nice, very clearly you can see some, if there's a big prolapse of mitral valve, you can see it from this view. Those are the things we can see from right parasternal long axis 4-chamber view. Then there are some measurements from this view. We will talk that later. Then we move to next view. This is right parasternal long axis 5-chamber view. In this view, we will get 5 chambers. To get this, we don't move the probe. We keep the probe in same position as earlier. Then third intercostal space, the angle is 45 degrees from chest wall. Then we rotate probe a counterclockwise direction. It's a slight rotation, very little. It's rotate up to 11 o'clock position. Earlier we were here, 12 o'clock position. Now we rotate this direction counterclockwise up to 11 o'clock position. When we move slowly, when we move this probe, we rotate this probe, we will get this image to screen. This is called right parasternal long axis 5-chamber view. In this view, we can see 5 chambers. First thing, left ventricle. A new chamber is aortic outflow tract. Here we can see aortic outflow tract. This is left atrium, right ventricle, right atrium. Here also you can see tricuspid valve and mitral valve. Then in this view, usually what we can do is we can measure the aortic outflow diameter, aortic diameter. Here we can measure the diameter. Here we can see, actually this image, it's not clear. You can see the aortic valve also. Sometimes we get intraventricular septal defect. So we can diagnose those intraventricular septal defect using this view. And to diagnose this intraventricular septal defect, we get the use of color Doppler. We can apply color Doppler and we can see turbulence. In this view also, we can apply color Doppler and get my aortic regurgitation or mitral regurgitation identified. Then we move to next view. It is right parasternal. Still we are on right side. It's right parasternal short axis view. Earlier we see the long axis of the heart. Now we come to short axis. In short axis, we don't change the animal position. We don't change the probe position. We just rotate the probe. When we rotate the probe up to 9 o'clock position. Earlier we were here 12 o'clock position, then we were here 11 o'clock position. Now we have come to here up to 9 o'clock position. So now we are at 9 o'clock position. So we will see the short axis view of the heart. In short axis view, to get optimized image, we'll have to fan this probe a little bit. We have to move the bottom of the probe a little up and down to get optimized image. This is how we see. Our probe is here. Ultrasound beam goes like this across the left ventricle. So this is left ventricular view. Right parasternal, short axis, left ventricular view. We will see the cross section of left ventricle. Here, this is the left ventricle. This round structure is left ventricle. You will see these 2 papillary muscles. And when we obtain this image, the image should be symmetric. We have to obtain the image more symmetrically. Then you will see right ventricle here, this part, this right ventricle here, you will see it here. Then this left ventricle here, we will see this lumen of left ventricle here. You will see papillary muscles inside this left ventricle. This is the intraventricular septum. You can see earlier also I couldn't tell you, this is the pericardium. You can see very bright structure here. This is pericardium. So we'll see these structures using this view. We can measure I'll explain this thing. Symmetric chambers and papillary muscles. This papillary muscles and chambers should be symmetric in this view. This is the optimum view. Then compare right ventricular anterior wall here, this right ventricular anterior wall with left ventricular posterior wall. So we can measure those views. Earlier on long axis also we talk about this measurement. Here also we can get the measurement. Anterior wall of right ventricle and posterior wall of left ventricle. Then we can get idea about contractions. We can see contractions. There's a measurement here. We can do that measurement using M-mode. I will tell that later. This view is called mushroom view. It's another name for right parasternal short axis left ventricular view. Then we come to right parasternal short axis mitral valve view. This mitral valve view, it's called fish mouth view because I think you can see this video here. It's like fish mouth. That's why it's called fish mouth view. In this view, we can see this mitral valve is moving. So we can see symmetric mitral valve if it is normal. If there's any abnormality or mitral valve prolapse, we can see asymmetric mitral valve here. In this view also, we do some measurement. We'll talk those measurement later. Then we come to next view, right parasternal short axis heart base view. And right parasternal short axis heart base view. Actually, there are two views of this. We'll have to fan the probe to get this view. From that previous view, we will have to fan probe a little bit towards the base of the heart. Then we will get aortic valve. Here, this is the aortic valve. You can see this is like benchmark view. You can see this cuspids here, here, here. Then it's like benchmark. That's why it's called benchmark view. So in this view, we can do some measurement. This is left atrium. This part is left auricle here. Then this is right atrium. This is right ventricle here. Then pulmonary vein is here. We'll see that later. Here also, this is left atrium. This is aortic valve. Here you can see right atrium. Here you can see right ventricle. So this is called benchmark view. Then we will move to next view, right parasternal short axis heart base view. Here optimized view for tricuspid valve. Sorry, pulmonary valve, and this is pulmonary artery. Here the pulmonary valve. This is pulmonary artery. You can see this is very nice clear image up to the bifurcation of pulmonary artery. We can see. Then, in this view also, we use color Doppler and spectral Doppler to do some studies of blood flow. In looking at this view, we can see whether there's any growth or any bacterial growth or any valve prolapse or anything. We can identify looking at this image. Then, we come to the next view. Left parasternal apical view, apical four-chamber view. Left parasternal apical. I told you that in the table there are two spaces. One table I show you, there are two spaces. When we keep the animal on left lateral recumbency, it's easy if there's much here also. But in this view, we keep the animal on left lateral recumbency. Then we keep the probe on the apical area, left apical area. Then angle the probe here, 30-degree angle from the body wall. Here, this is the body wall. We angle the probe 30 degrees. It's very small angle. So in the normal table also, we can do this examination because this angle is very small angle. Without this, here I don't have much, but I can do the examination because this angle is 30. Then, when we keep the probe here, that's marker towards the dorsal side. Here, still we most of the time in echocardiography, we point the marker towards the vertebral column of the dog. Then, this is the left parasternal apical 4-chamber view. In this view, this point marker towards this direction. So you have heart like this. This is the left ventricle, right ventricle, right atrium, right left atrium. So we will see the view like this. In this view, we keep the probe from the apex of the heart. Then we can see heart like this. In this view, we can use color Doppler and spectral Doppler to measure the velocities and blood flow through the heart easily from study the mitral valve. This is next view, left parasternal apical 5-chamber view. In this view, we slightly rotate the probe counterclockwise direction. When we rotate the probe from that 4-chamber view, this aorta will appear in the screen. This is the aortic outflow tract. This is, you can see aortic valve and aortic outflow tract. This is called 5-chamber view. In this view, we can evaluate the aortic valve function. To evaluate those functions, we use spectral Doppler and color Doppler. Then, the next, we are going to talk about measurement. Now we have talked about optimized views. Those are the views I am going to talk today. So from those views, we can do some measurements. Using this measurement, we can come to certain type of diagnosis. First view, right parasternal long axis view. This B mode measurements are there. So we measure mitral valve annulus. This mitral valve annulus means the actually the diameter of this mitral valve. We can see this mitral valve hinge to this mitral valve hinge. This length measured in end systole and end diastole. In cardiology books, you have reference for these values. Using these values, we can do certain diagnosis. But these values depend on the breed and the weight of the animal. So we can't get just a specific value for this measurement. Then we move to ejection fraction. This is very important measurement we measure in echocardiography. The ejection fraction is the percentage of blood that pump out of the filled ventricle with each heartbeat. From one heartbeat, the percentage of blood pump out from that. This is normally, we consider 40% or above is normal. Normally, ejection fraction should be above 40%. If it is below 40%, we consider it's reduced ejection fraction. Then, especially in Doberman and large breed dog, they get dilated cardiomyopathy. In dilated cardiomyopathy, this ejection fraction is less than 25. Usually, this is the reference value we use to diagnose this DCM, but there are some other measurements But this is the easiest measurement we can do in echocardiography and diagnose this dilated cardiomyopathy. Then how do we measure this ejection fraction? There are two different methods to measure this ejection fraction. First method is called Simpson method. In Simpson method, you will have to measure the area of left ventricle both during a systole and diastole. In that, first you have to get diastolic volume, then you'll have to get systolic volume. Then we can do the calculation. Those in nowadays, if your ultrasound machine support to do echocardiography, this machine software support this measurement. You can draw this area using your cursor, and it will automatically get the surface area, and it will do the calculation. But this is little time consuming, and you'll have to get so there are another method to measure the ejection fraction, but this method is most accurate method. So this is right parasternal long axis 4-chamber view. We can measure using this view, or we can do this using left apical 4-chamber view also. Then we measure the diameter of atrium and ventricle. We measure this in end systole. We can measure the atrial diameter and the ventricular diameter. Usually this is same size. If there's a change here, you can easily say there's a atrial dilatation or ventricular dilatation. This should be 1-to-1 ratio. Then we come to EPSS. This is endpoint septal separation. This means the distance between tip of cranial mitral valve leaflet to the intraventricular septum. Here you can see this is the intraventricular septum. This is the tip of mitral valve. So the distance between this tip and the minimum distance between this tip of the mitral valve leaflet and intraventricular septum is called E-point septal separation. In this E-point septal separation, we can measure using this view. This is 4-chamber view. You'll have to freeze the image and scroll back and get the measurement. Then otherwise, you have to go to this right parasternal short axis mitral valve view. Then we have to apply M-mode, and we can map the contraction of the mitral valve over time. Then we can measure the distance here. You will get same measurement from this both views. This is EPSS. That's a reference value for that. Some people say this is up below 6.5, but usually we get below 9 millimeters. This below 9 millimeters, this EPSS, if it is above 9 millimeter, it's suspected to DCM, dilated cardiomyopathy, especially in Dobermans and those large breed dogs. Then, color Doppler. In color Doppler, I told you that we use this color Doppler to map the flow direction or detect turbulence. Here in mitral regurgitation, there's a regurgitation jet. This regurgitation jet, we can see there's a turbulence. This turbulence is in usually yellow, green, or bright blue color. So here we can see this turbulence. So there's a mitral regurgitation. The severity of this mitral regurgitation can be assessed here depending on the percentage of regurgitation checked. if the area of this regurgitation jet is above 70%, it's called severe mitral regurgitation. If it is below 30%, it's a mild mitral regurgitation. So you can identify the mitral regurgitation severity, but it's subjective measurement. So if you want to measure the severity, best thing to go for spectral Doppler. Here you can just get idea about mitral regurgitation. Then wall thickness. I told you in this 4-chamber view, we can measure the ventricular wall thickness. Left ventricular posterior wall thickness and interventricular wall thickness. We can measure this wall thickness, especially in cats. Cats, a very common disease in cats, it's hypertrophic cardiomyopathy. In hypertrophic cardiomyopathy, the ventricular wall thickness is greater than 6 millimeter. When we measure this ventricular wall thickness, the more than 50% of this ventricular wall should be greater than 6 millimeter to interpret this as hypertrophic cardiomyopathy. Usually what we do is we do 4 measurements from ventricular wall. So one measurement here, one measurement here, here, and here. Again, you come to the interventricular septum, and septum also we do 4 measurements. Then only you can go for interpretation. It should be more than 50% of the wall thicker than 6 millimeter to interpret as hypertrophic cardiomyopathy. Sometimes, but you will have to exclude hypertension and hypothyroidism and those conditions before interpreting this as HCM. Remember, this is cat. Usually, dog doesn't get hypertrophic cardiomyopathy. Then, left ventricular outflow tract diameter. Here you can measure the left ventricular outflow. This is for 5-chamber view. Right parasternal long axis 5-chamber view. In this 5-chamber view, you can measure the aortic diameter or left ventricular outflow tract diameter. This diameter is compared with the right ventricular diameter, and we do some not right ventricular diameter, left atrial diameter, and we do some interpretation. I will explain you that later because we have another measurement here. Then this view also we can apply color Doppler. After applying color Doppler, you can identify aortic insufficiencies. If there's aortic insufficiency here, you will get turbulence here. Then if there's any abnormal communication. What is this abnormal communication? Abnormal communication means intraventricular septal defect. When there's intraventricular septal defect, you can see turbulence in between these chambers. So you can identify septal defect in this view. Okay, then we move to another measurement. Here, measurement of short axis view. Right parasternal short axis view at the level of left ventricle. So we get the cross section of left ventricle here. Then we apply M-mode cursor here. When we apply M-mode cursor, you will get M-mode map on your screen. Here you can calculate ejection fraction. This is called Tekil's method, Tekpol's method. This Tekil's method, we can easily calculate ejection fraction. But this is not highly accurate method, but this is the easiest place we can do the ejection fraction calculation. In this calculation, you will have to do some measurement. In ultrasound machine, there's a built software. When we select this ejection fraction calculation on M mod, you will direct the machine to measure these things. Some machines start from right ventricular diameter, from here. Some machines started from interventricular septum, then left ventricular diameter and posterior wall thickness. Then again you measure interventricular septum, left ventricular diameter and posterior wall thickness in systolic. After you do this measurement, diastolic right ventricular lumen, interventricular septal diameter, then ventricular lumen, then left ventricular wall thickness, those things, you will get the calculation of ejection fraction automatically from the ultrasound machine. This is the easiest place we usually practice to calculate ejection fraction. Then we move to another measurement from left ventricular, right parasternal short axis view, mitral valve. In mitral valve view, we can get EPSS, endpoint septal separation. So we apply M-mod cursor on this view, then you will see the movement. Then we can measure the endpoint septal separation, EPSS, here. Earlier we told this reference value for this is about 9 millimeter. If it is above 9 millimeters, we suspect it as dilated cardiomyopathy. Then we come to this ratio. I told you I'll tell you this ratio later. This is the measurement of right parasternal short axis view at the level of heart base. This is aortic valve view. In this aortic valve view, we measure aortic outflow diameter. This is aortic outflow diameter. Then this is left atrial diameter. This left atrial to aortic outflow ratio should be between 1.8 to 2.4. If it is above 2.4, we call this left atrial dilatation. If there's left atrial dilatation, this goes about 2.4. Sometimes when there's aortic outflow tract dilation, this is below 1.8. This is below 1.8. Sometimes in chronic high blood pressure and some cases, you will get dilated outflow tract, dilated left ventricular outflow tract. So you can diagnose this using this measurement, LA-LR ratio. Okay, then measurement of right short axis, right ventricular outflow view. This is the right ventricular outflow view. You can see this pulmonary artery here. This is the pulmonary valve. So we can measure the diameter of this pulmonary valve. You can measure any insufficiencies. When there's insufficiencies, you can apply color Doppler here. In applying color Doppler, you will see turbulence. Then we can apply pulse wave Doppler here and measure the flow. We can measure the velocity through this valve, and if there's the regurgitation or if there's any problem, we can apply continuous wave Doppler and measure high velocities. Then another thing is PDA, patent ductus arteriosus. We can diagnose this using this view. You can see here, this is the pulmonary artery. You can see pulmonary artery up to bifurcation here. Usually, this is the place of ductus arteriosus. So, if there's a PDA, we can apply color Doppler here. When we apply color Doppler here, you will get turbulence like this. And this image, you will see this clear turbulence here. This is PTA. So we can diagnose using this view. Then, this is how you apply spectral Doppler. This is pulse wave Doppler on pulmonary artery, pulmonary valve, and you can see the flow here. If there's regurgitation, you can identify here. You can measure the velocity here. There are some reference values for these velocities also. If you want, you can go through those books and get those reference values. But this is the place we do this measurement. Okay. This is now we move to left apical view, left parasternal apical view, 4-chamber view. In this 4-chamber view, I told you that we can measure the ejection fraction using Simpson method. Here we measure the sub area of left ventricle in diastole and systole. When we measure those areas, you will get clearly you will get the ejection fraction calculated from the machine. Okay, then we move to color Doppler. From left apical view, we apply color Doppler on mitral valve. Left apical 4-chamber view, we apply color Doppler. When we apply color Doppler, if there's a mitral regurgitation, you will see clear turbulence jet. This is the mitral regurgitation jet. You can easily identify mitral regurgitation here. Then after this, we apply a spectral Doppler here and measure the velocities of the mitral regurgitation, or if it is normal mitral valve, we can measure the velocity through mitral valve. This is how we apply pulse wave Doppler over mitral valve. We have to identify the tip of this mitral valve leaf and put the cursor here. This is pulse wave Doppler cursor. When you apply this cursor here, you have to keep your probe without moving steadily. Otherwise, you don't get this. Then you will get this fluid movement over this valve. Here there are two waves. First one is called E waves. Second one is called A waves. So looking at this, you can identify normal blood flow. If there's regurgitation jet, you will see it here. You can identify the regurgitation jet, but usually you can't measure the regurgitation using this pulse wave Doppler. So you will have to apply continuous wave Doppler to measure the regurgitation. This is continuous wave Doppler. You have apply over mitral valve. Then you can easily measure the flow. Backflow is here. This is regurgitation. You can measure the velocity here, regurgitation velocity. Then we come to outside the heart, you get pericardial effusions. In pericardial effusion, you will identify fluid around the heart. You can see here this bright line is pericardium. In between heart, the posterior wall and the pericardium, you will see fluid. This is pericardial effusion. Using ultrasound guide, you can drain this pericardial effusion. There are techniques to do that. Then finally, I will show you this cellular endocarditis, this vegetative growth on mitral valve. Like this, you will get this bacterial growth like this in mitral valve, sometimes tricuspid valve. Most commonly, we get this type of vegetative bacterial growth on the tricuspid valve. then we get mitral valve. Sometimes I don't know, I haven't seen on aortic valve. Okay, Chandika, that's all my presentation.
Yeah, thank you very much, Dr. Mathota. Now the lecture is open for any questions. If you have any questions, either you can directly ask Dr. Mathota, or else you can type the questions in the chat box.
Dr. Mathota, I have one question.
Yeah.
Hello.
Yeah, I can hear you.
Yeah. Can you go to the slide again to DCM?
Yeah.
You explain
DCM means
no. Can you go to that slide and explain that slide, please, again?
that is
Not that one.
M-mod measurement.
No. Not that one.
Fine.
Not that one. Previous one. Where you explain dilated cardiomyopathy.
This one.
Yeah.
The ejection fraction. Usually we measure ejection fraction using this method. I told you here. This method, Techie's method, Tickall's method. In Tickall's method, we measure this ejection fraction and we get the calculation from the ultrasound machine. After you get the calculation, we come to this ejection fraction. If the ejection fraction below 40, it's considered, if it is above 40, it's considered normal. If it is below 40 ejection fraction, it's considered reduced ejection fraction, but it is not dilated cardiomyopathy. But if the ejection fraction is below 25%, most of the time we diagnose as dilated cardiomyopathy. But chamber enlargement also should be there. There are some other things to see, but this is good measurement to diagnose dilated cardiomyopathy.
Okay. Thank you. Thank you, Dr. Mathota.
Okay.
Any other questions from the audience, please? Until others ask questions, Dr. Mathota, can I get another clarification from you?
Yeah, sure.
Now, regarding this LAA or reference range, I'm a bit confused. You mentioned
Yeah.
about it being normal from 1.8 to 2.4.
Yeah.
Yes,
So,
Dr. Chandika, I also have some doubt in there. Can you remember some cardiologists came from some country to Petway that at that time they explained the reference value is 1.6 to 1.9 is normal like that or something. I can remember like that.
Yeah, the different books we are also have, I have seen these different books 1.5 to 2 and like that in different places, but I think this is more accurate. When we diagnose, we get this is the best value, I think, but there are some different reference range for this one.
So you have seen an actual clinical relevance to when it comes to 1.8 to 2.4 range. Is that so, doctor?
Yeah, I think because in some places we sometimes if we tell there's a left atrial dilatation with below 2.4 patient, I think clinically in X-rays and all you can't see that.
All right, okay. Because I was always under the opinion that it should be normally 1.6 for it to be normal LAO ratio. So have you seen like about ratios of 3 kind of when it comes to?
Sometimes there are some ratio more than 3, 4. Sometimes it goes up to 4 in severe dilatation.
Right. Any other questions from the audience?
Usually in mitral valve disease, if there's mitral valve regurgitation, you get very big left atrium.
Right. Okay, we have about another 10 more minutes. We can entertain few more questions if the audience has.
I think chat box, no.
They are all thanking you. Thank you, Dr. Mathota. Very clear presentation. Thank you. Excellent. Veterinarians who have actually
Dr. Mathota, hello.
Yeah. Can you hear me?
Yeah. Can you go to the slide again? You get a measurement from mitral valve leaflet to intraventricular septum slide. Can you explain that slide again, because it's little bit difficult to understand.
This one place in M mode. Here was there's another place to measure that. Yeah, this slide, no?
Yes, this one. Yes, this one.
This is the intraventricular septum. This is the mitral valve leaflet. We measure the distance between this mitral tip of this mitral valve leaflet to intraventricular septum. That is called EPSS.
Okay.
This EPSS reference value is some places. This also I have seen 6.5. Some places it's called 9. Usually I use this 9 value. If it is above 9, it's a dilated cardiomyopathy.
Right. Above 9. Okay. Okay, thank you, Dr. Mathota, for that. Dr. Chandika.
Yeah, I would invite vets who have scan machines to get the maximum use of this session and ask any question, any clarification that you have faced during the actual cardiac scans.
Actually, it's different scan machines. You will have different measurement software. Usually for this ejection fraction, in some machines you can easily calculate ejection fraction. Some machines it's a little bit difficult. But always we have to use the inbuilt calculation software to calculate ejection fraction. In some machines, you have software to calculate this EPSS. You will get that in report. But some machines, they don't have inbuilt software. You will have to manually measure and include it in reports.
Right. And also, Dr. Mathota, you mentioned about frequency range from 2 to 8.
Yeah.
So if a machine frequency starts from 5.5 kind of, would you feel very challenging?
Yeah, that's the thing. If the frequency is 5.5, when you come to large breed dogs, sometimes maybe grade 10, that Ridgeback you don't get clear images.
So if you have the option, you would always go for 2 or 3 for a large breed?
Yeah, that's the best thing. Then you will get clear images. Otherwise,
Dr. Mathota,
the area of the image is not clear.
Dr. Mathota, can I interrupt? Yeah. In my machine, the frequency range is 3.5 to 8.5.
Sorry?
In my machine, the frequency is 3.5 to 8.5.
Yeah, that's good range, I think. 3.5, you can see most of the patient you can see. And my machine also, I have, I think, from 4 to 4 to 10, I think. So that's good range.
Oh, because I'm worried because I don't have two frequency in 2, no? That's why I asked that question.
Thing to have a Pacere probe to do echocardiography. With microconvex probe, it's a little bit difficult to do this clear images. You can get images, but optimized image, it's a little bit difficult.
Yeah, because I don't have Pacere one. only microconvex.
These images are from Pacera probe. If I get this image from microconvex probe, it's not clear like this.
Okay, okay. Understood. Thank you.
Okay, then in the absence of other, like any other questions, I will.
Hey, President, do you have any questions? Dr. Randika? Dr. Randika?
Till is ready, then shall I ask another question from Dr. Mathur to get maximum use of Dr. Mathur from this session? Dr. Mathur, like what are the like advantages that you would see if we do the scan while fixing the ECG probes at the same time?
Definitely, it's very important because if you measure the ejection fraction, get correct systolic point and diastolic point, you should have ECG. But most of our machine, we don't have ECG machine. That's the problem because it's with the technology and expenses. If we have ECG machine, always better to connect it and get the measurement.
So under Sri Lanka situations, you would like rely on your experience and like expertise to find the exact places of diastole and systole. Is that so, Dr. Mathura?
Yeah, but it is subjective. Sometimes you will get wrong measurement when we do that.
Right. Okay.
But if you have ECG, you can get correct point, exact correct point.
Any other questions from the audience?
Actually, I think only one machine I have this ECG here.
In Sri Lanka, you
but it's technically there's a problem with connecting it also.
So in the absence of any other questions from the audience, I would invite Dr. Sugat Premachandra to deliver the vote of thanks officially.
Thank you very much, Dr. Chandika. Dr. Randika Gunawardena, the President of Sri Lanka Veterinary Association, and our resource person today, Dr. Tushar Mathota. Dear doctors, ladies and gentlemen, on behalf of the 73rd Executive Committee, I take this opportunity to extend our most sincere gratitude to our resource person, Dr. Tushar Mathota, who accepted our invitation as resource person despite his busy schedule. We believe that knowledge we have shared will help immensely to improve the skills of veterinary surgeon in Sri Lanka. Actually, it's a very creative, informative, and very clear presentation. Thank you very much, Dr. Mathota. At the same time, we are grateful to Dr. Chatika Vikramasinghe for your special support to make this workshop a success as moderator. And also, I would like to thank all the doctors and the students who participated today to make this workshop a success. Thank you very much.
Okay, thank you very much, everyone.
Thank you very much.
Thank you.